All right, thank you very much for inviting me to speak on the 5 most important things to know regarding providing care for patients with heart failure. I have no disclosures related to this presentation. So first most important thing to know about managing patients with heart failure is that ongoing congestion is common amongst ambulatory patients with heart failure. And we have lots of data that backs this up. Here are 2 graphs that show the difference in weight from when patients are admitted with heart failure to when they're discharged. On the panel on the left here, this comes from an Saturday trial looking at using intravenous BNP for treating heart failure. And what you can see here that on day 1 of hospitalization, there's a fair bit of weight loss. There's a little bit less weight loss by discharge or day 10, with a substantial amount of patients already gaining weight beyond their admission weight. And then by 30 days after hospitalization with heart failure, 50% of patients are over the weight they were in than when they left the hospital. Similarly, you can see this is just represented in a different way from a different trial, looking at the degree of congestion. And while it's true, by the time patients are discharged, many of them have been decongested, there's still a substantial portion that remain congested. You can look at this in another way. This is a study that was published just about 2 years ago, looking at the prevalence pattern and clinical relevance of ultrasound indices of congestion. And when I asked my house staff that work with us, what percentage of patients are congested when they show up to clinic, my somewhat cynical answer is it depends how closely you look. And this is a great example where they looked at 342 patients. Around a third had clinical congestion, but when you combine that with clinical or ultrasound evidence of congestion, that was clearly a majority, with only a minority having no congestion at all. These are patients or well patients showing up to clinic. So congestion is quite common, but as important as the fact that congestion is common, congestion itself portends a poor prognosis, and treating it improves outcomes. So how do we know this? This is an example that comes from 2010. It's already 10-year-old data that shows that depending on the type of congestion that's evidenced, your mortality can dramatically increase. So in patients who are completely compensated without signs of congestion, their outcome at 840 days is reasonable. If they have peripheral edema, it's not terrible, but not as good as without congestion. And of course, if they have ascites, that really signals a very, very guarded prognosis. And another way to look at it is in the amount of signs of congestion. So if a person has a single sign of congestion, that affects the prognosis somewhat. But if they have more than 3 signs of congestion, their prognosis at 840 days is really quite guarded. And another way to look at this is if you combine signs of congestion with degree of renal dysfunction, there's a synergistic effect. This is one of those 3-dimensional graphs that really show the patients that are very congested with poor renal function have a very high hazard ratio of having poor outcomes. You can see a similar thing in patients who leave hospitals still congested. Again, the best way to have a patient re-hospitalized from a heart failure admission is to send them home still congested, and that's shown on the left panel over here. And in fact, it's not just about getting rehospitalized, but in fact, all-cause mortality is significantly increased at 3 months in patients who are still congested by day 7 or the day of discharge. And this is relatively contemporary data published in the International Journal of Cardiology. And this is the controversial part. This is what we struggle as primary care doctors, as cardiologists, as heart failure cardiologists. What is the evidence that decongestion improves outcomes? And it's a little bit hard to prove. In fact, there's only a single prospective placebo-controlled trial looking at diuretics and conventional outcomes in chronic heart failure. And it enrolled a total of 38 patients. It was performed in 1985 using a diuretic called portends, which I can't even pronounce and have never used or seen, for 4 weeks. So very, very limited data that shows that actually decongesting people improves their outcomes. And we know that diuretics are associated with poor outcomes in ambulatory heart failure. The higher the diuretic required, the worse the outcome. And this is borne out in registry data and some of our risk stratification models that I'll speak about a little bit later. So how do we know that they work? And to some degree, diuretics are sort of like testing a parachute. We know they work because we just see it in clinic, and certainly patients feel better. It does become trickier, though, when patients are minimizing their symptoms or they're limited for other reasons, especially older patients. And it becomes a bit trickier to know that truly decongesting them is going to be good for them. Some of our best contemporary data about diuretics actually comes from our CardioMEMS data. For those of you who are not aware, I think I've discussed this in previous years, but CardioMEMS has taught us a lot. It is a device that can be implanted in a patient. It is essentially a Swan-Ganz catheter patients can go home with, and it measures their filling pressures. This is just a short video that shows you how it goes in for those of you who are interested. But essentially, you put it in like a swan into the pulmonary artery, and you kind of leave a pressure transducer there, which can then wirelessly transmit data to a pillow that patients lie on, and then gets uploaded to a website so we can track these patients. And here you see the sensor being deployed within a pulmonary artery. And it does not occlude the vessel. It takes up a small proportion of the diameter, as they're about to show over here. And in fact, when we looked at this, this was studied in a randomized way, controlled way back almost a decade ago now. And what they showed was in the control group, there were far more hospitalizations and days spent in hospital than there were in the treatment group. And what's key about this trial, not only does it work, but it actually works in all kinds of heart failure. So Dr. Balmain will be speaking a lot about evidence-based therapy and heart failure reduced ejection fraction in the next talk. But this kind of intervention where patients have their filling pressures and evidence of congestion tracked closely, invasively, but in an ambulatory setting, works in people with ejection fractions that are less than 40%, greater than 50%, in that elusive range, 40 to 50%, for which we have absolutely no data on any other effective therapeutic strategy. And these patients that were enrolled in the initial trial, the Champion trial that was published in 2011, maybe a bit younger than some of the patients that we typically see in our heart function clinics, but certainly comorbid, just like the patients we see in a heart failure clinic, with many of them having diabetes, hypertension, atrial fibrillation. And you'll note here that upon registration into the trial, in fact, all of them had pulmonary hypertension, evidence of, in fact, that they were already congested by the time they got enrolled, and the enrollment, of course, took place in ambulatory clinics. What's really interesting to me is that, in fact, putting a sensor in somebody to monitor their pressures doesn't actually change anything. So when they actually looked at trying to figure out what it was about having these patients have their hemodynamics monitored closely that led them to not be hospitalized as much, what they found was, of course, it was a much more intense changing of medications, and specifically triple the amount of diuretic adjustments, with small numbers of vasodilator adjustments, adjustment in ACE inhibitors, and adjustment of beta blockers. So to me, this tells me that by adjusting their diuretics, and most of this were increases in diuretics, that they were able to keep their patients out of the hospital. So pretty compelling data. The decongestion is probably a good thing. The third thing I want to talk about is that prognosis in heart failure is highly variable, and all of us have been in clinic. We specifically get it in advanced heart failure clinic, but I'm sure as primary care doctors, you get this in clinic too. A patient's just left the hospital after being admitted for heart failure, and they Google this thing and they say heart failure has this terrible prognosis. And this came from, this initial concept about how bad the prognosis for heart failure came from a paper back in October of 2000 by McMurray and colleagues that demonstrated that once you get admitted for heart failure, your prognosis, as measured up to 5 years, is as bad as some of the cancers that you might get admitted with, and potentially worse than bowel, prostate, and bladder, and only just slightly better than advanced lung cancer. But of course, we know that's not completely the full picture. And we know that, in fact, heart failure prognosis is quite variable. And this is a classic graph that we use to teach patients and our house staff about the clinical trajectory of heart failure, where we see that heart failure is characterized by periods of stability, unfortunately, sudden deaths that happen that are quite unpredictable, and even in patients who are doing quite well. That's symbolized by these dashed arrows over here. And then long periods of clinical stability, as evidenced by this broken graph over here. And even when patients develop advanced heart failure, they can remain stable for periods of months and years, and it can be quite unpredictable. The way we prognosticate in heart failure is by using modeling. And this is the MAGIC score that you can easily Google. And just as an example, just to give you an idea about the heterogeneity and somewhat counterintuitiveness about prognosis in heart failure, if you have a 55-year-old who has an ejection fraction of 25%, who's feeling relatively well, their 1-year mortality is really 3.6%, or almost a 97% survival at 1 year and over 90% survival at 3 years. Whereas if you took a 75-year-old with heart failure and preserved ejection fraction who was highly symptomatic, their prognosis was far worse. So this is just to illustrate that prognosis is variable. It's highly dependent on symptoms, and the clinical course is a little bit difficult to predict and much less predictable than advanced cancer. Item number 4 of the 5 most important things to know about heart failure is that recognizing patients who are in trouble is critical. And why is it critical? Well, in younger patients, and by younger I mean less than the age of 80 or 70 to 80, we have advanced heart failure therapies that are potentially helpful in these patients. Up to the age of 70 to 75, we would consider cardiac transplant in those with poor prognosis from their heart failure. Mechanical circulatory support up to the age of 75 to 80, we've done some in the 75 to 80 range, and certainly in the United States, they've done patients in their early 80s. And we have other options like remote monitoring, not just CardioMEMS, but we at UHN have been rolling out the Medley program, where patients can be monitored for daily weights and vital signs with email triggers to help prevent people from being rehospitalized. And of course, we have the ability to enroll patients in palliative home care, and all patients potentially can benefit from that. And by example, one of the clinics that we've started here at Mount Sinai Hospital is an OTN clinic for the elderly and frail. And this is just an example of where we looked at 40 patients with advanced heart failure with an average age of 85, highly comorbid, high chance of dying in the next year or even 3 years. And what we showed by enrolling them in this kind of clinic, by identifying them as high risk and then enrolling them in this clinic, is that we were able to reduce their all-cause hospitalizations, their ED visits, their amount of days they end up spending in the hospital. All statistically significant, quite meaningful to the patients, and this despite the progressive nature of the disease. How do I know my patient may be at risk? Well, I've given some clues that we often look for: progressive renal dysfunction, elevated diuretic requirements, recurrent hospitalizations for heart failure, impairment of function, and then symptomatic hypotension that requires the reduction of medical therapy. And I've made this so that it forms PARISH as an acronym, in case you want to remember these things. And this would definitely be a trigger for your patient to be seen by their cardiologist, and even a trigger for their cardiologist to potentially refer them to an advanced heart failure cardiologist. The pro tip: if the patient's unable to walk a single block or is breathless while bathing or dressing, their prognosis may very well be compromised, and that should be a tip that the patient's not doing particularly well, and perhaps therapy and assessment needs to be intensified. And the number 5 most important thing to know about heart failure is that stopping heart failure medications can be problematic. And Dr. Balmain's going to be going through sort of some of the routine medications that some of the patients are on. But one of the things that comes up a lot in the clinic is the patients have been seen by other practitioners, other specialists, primary care doctors, or emergency room physicians, and there's a temptation for the medications to be stopped. Also, patients often ask, can I stop my heart failure medications? And so the answer to that is probably not. We learned this lesson, way back in 1997 with the DIG withdrawal trial that showed that patients who were stabilized on DIG, when you stopped their digoxin, they ended up having worsening heart failure. So this is already 23-year-old data. And just recently, published about 2 years ago now, in the Lancet, the UK group looked at withdrawal of pharmacological treatment for heart failure in patients with recovered dilated cardiomyopathy. So, many patients do recover when they're diagnosed with heart failure, reduced ejection fraction. And they tried to withdraw therapy and stabilize patients. And what they found was that either the patient's ejection fraction dropped, or their LV dilated, or their BNP went up by 6 months. And you can see here on the table on the graph on the left, that the control group remained free of events, whereas the treatment withdrawal group ended up with events. Now, they didn't wait for clinical events. These were biochemical or diagnostic laboratory events, but still, this was pretty compelling data that once patients are on heart failure medications, unless there was clearly a reversible cause, they should remain on them indefinitely. So there are some times when patients come in sick with other things that we do have to stop the medications, but a collaborative approach is key. Medication withdrawal should be discussed with their other care providers, including their cardiologist or the heart failure specialist where possible. If patients are feeling well, then generally we try to avoid changing their heart failure medications, withdrawing them specifically. If a medication has to be minimized, has to be stopped, then to minimize the length of time that it's stopped, the patient has to go for surgery, or if they're dehydrated from a viral illness, it can be stopped briefly, but then restarted as soon as possible. And then to potentially consider a nuanced approach, including substituting medications or reducing dosages rather than completely stopping them. So an example here might be if a patient comes in with acute kidney injury and there's a temptation to stop the ACE inhibitor, in patients with heart failure and reduced ejection fraction, we might consider substituting hydralazine for an ACE inhibitor that doesn't impact renal function, but can act as a potent vasodilator so that the heart's not struggling against an increase in afterload suddenly. And again, all of this just requires careful discussion and consideration, ideally with the patient's physicians that have been looking after them.